Good afternoon. My lecture for Rhinology Worldwide video textbook is Allergic Rhinitis and specifically allergy testing for the diagnosis of allergic rhinitis. My name is Elina Toskala. I'm professor at the university, at Thomas Jefferson University, Philadelphia, at the Department of Otolaryngology, Head and Neck Surgery. My disclosures are here and don't affect this talk. I'm going to first talk about definition of allergic rhinitis and allergy sensitization. My talk is based on all the evidence to our international consensus statement on allergy and rhinology, allergic rhinitis, that as one of the editors with Dr. Weiss and Dr. Lin, we had a significant amount of national and international experts to make this document that basically looked everything evidence-based in allergic rhinitis. You also see a free download link at the bottom of this, so you can get all the evidence that you want to check or you need for anything of your own clinic and work from this site. This was published in International Consensus in Allergy and Rhinology Journal. Allergic rhinitis definition. In atopic individuals, exposure to allergens may prompt antigen-specific IgE production. When you first encounter these allergens, you really don't get a reaction. It's a reintroduction of the allergen that when you have developed the IgE, you will get early stage reaction in allergic rhinitis with nasal itching, nasal congestion and rhinorrhea, and late states 4 to 8 hours later, nasal blockage, hyposmia, increased secretion, and nasal hyperresponsiveness. A lot of patients who have had long-time allergic rhinitis have more of this chronic nasal congestion and maybe a little less of runny nose, but you can have both. And if you have a seasonal allergy at the beginning of the season, you get the early stage symptoms, and then later on the season, it might turn into the late stage. Allergic rhinitis has been classified in the past, and we still use this seasonal and perennial. The problem with this classification is that not every area in the world has seasons, or some areas might have 2 seasons, some might have just 1 season. We living here in East Coast of US or in Europe, we have 4 seasons, and that's how we always used it. So allergic rhinitis and an impact on asthma expert group that I was also part of decided that it would be better to divide it intermittent or persistent allergic rhinitis, and then look the severity separately, whether this intermittent or persistent allergy is mild or moderately severe. Intermittent is disease when it's less than 4 days a week or less than 4 consecutive weeks. I think sometimes it's a little difficult to explain patients intermittent or persistent when they are not sure how their symptoms come and go. And if you have a lot of allergens, you can have kind of both of them. You get symptoms more during certain seasons, but with your year-round allergens, you still can have underlying persistent. So you kind of can have even both of these. What about sensitization? With allergy testing, we are looking for sensitization. You have monosensitization when you are allergic to one allergen and you are monoallergic. You are polysensitized when you have more than 2 allergens and you are polyallergic. Well, what does this make a difference? For immunotherapy especially, we always would like to treat all the allergens that patients are sensitized, and it's more difficult if you have multiple allergens, over 10 allergens, and then you start picking up your allergy immunotherapy. And then also this often depends on the area where you are. Some areas have very strong pollen season for few plants, and you get less different allergy sensitization than some other parts of the world. The fact that you find sensitization in allergy testing is just that. It doesn't mean that patient is allergic unless the symptoms also occur at the same time as the allergy season is. So positive test might just mean that you are atopic, but you might not have an allergic disease yet. To develop allergic disease means that you also get the symptoms from the allergy exposure. ICAR document also looked how many PubMed references are for different kinds of diagnosing allergic rhinitis, and you see here the table of them. A lot of things have been published, and I'm going to go through those that have the evidence best for your clinical work. So in general, diagnosing IgE-mediated allergy, you can use skin test, you can measure serum-specific IgE, look into histamine release, basophil activation, or do a nasal challenge or bronchial challenge, oral or even conjunctival challenge. First, we talk about skin prick test. That's probably the most commonly used testing. It's an easy and quick. You need a histamine control and positive control to make sure that if your positive control is positive, it means patient have dermographism, and that means that any scratch on the skin will cause a reaction, and you can't trust any of the positive. On the other hand, if the negative control is negative. So if histamine doesn't cause reaction when it should, you can't trust the negative result, meaning that patient don't have allergies. And all these situations, it could be dependent on the medication patients are. I'll talk a little bit later about what medications has to be avoided before allergy testing. And then you would want to do the blood work for allergies. 1 millimeter reaction is positive. Here's just on the right side, the list of allergens that are often specific to the area where you live. You try to adjust that as much to the area, pollen seasons as you can, so that you can test your patients exactly the things that they are going to be exposed. Skin prick test is used to confirm diagnosis of allergic rhinitis. Obviously, history and symptoms is the critical. It can direct allergy immunotherapy, and the cross-link of IgE to the cutaneous mast cells results the release of mediators, including histamine, which then causes the wheal and flare within 15 to 20 minutes. That's when you read the test. There are no fatalities reported, but there is a potential risk for anaphylaxis. And therefore, especially in the United States, people don't do skin tests if patients are on beta blockers. Idea here is that if you get anaphylaxis and you're given epinephrine, being on a beta blocker would prevent the epinephrine helping the patient. You don't want to do on patients who have severe asthma, exacerbation, uncontrolled cardiovascular disease, again, like I said, beta blocker use, or they are pregnant. Sensitivity and specificity of skin test is about 80%, so it's very good. Obviously, again, it's not 100%. Here's just a kind of a big table from ICAR. This is how everything that we looked were presented at the end. You have the aggregate grade of evidence, which is B for skin prick testing. There's a list what are the benefits, the harms, the cost, which for skin prick test is low, balance of benefit and harm, which for skin test is preponderance of benefit over harm. You have a value judgment and policy level, which is important. This is the recommendation. We recommend skin prick test as the test for allergic rhinitis based on the evidence. How you read this, skin prick test is recommended for evaluation of allergen sensitivities in appropriate selected patients. You would want to use standardized allergen extract. What about intradermal testing? It can be used for, again, for diagnosis of allergic rhinitis. Some people use it as a primary testing, but many people use it as a secondary testing following skin prick test. It can be used for starting point of allergy immunotherapy if you don't want to start on a standardized dose, but on some antigens you want to start on a higher dose and some lower, depending how the intradermal testing starting point shows what's safe. It's used for vial test and can be evaluated of sensitivity of other substances. like some medications, foods. It's done by injecting 0.02 milliliters of the antigen producing 4 millimeter wheel that then will let to expand to 5 millimeter. You need again histamine control and negative control. Observe 10 minutes and 7 millimeter reaction is thought positive. It's more demanding technically a skin prick test, and it also takes longer time. The adverse events are rare, but there's been few fatalities reported. Evidence table for skin intradermal testing shows aggregate grade of evidence B, balance of benefits and harm, benefit over harm when used as a standalone diagnostic test, balance of benefit and harm when used to confirm the result of skin prick test as quantitative test or as a vial test is safe, meaning that there's about the same balance between the benefits and harms. Policy level is an option. This is more expensive, takes more time, and some question whether you need to really do intradermal testing to get the reaction. If you have to wait and do this before you get a reaction from a negative skin prick test, is this clinically relevant allergy? But this is an option for testing. Then you can have this blended skin testing, modified quantitative testing that I used often to allergy immunotherapy start. It's less time consuming than intradermal testing, additional risk and time involved, placing the intradermal portion of the test compared to the skin test. And it's cheaper than intradermal test and in vitro test, but it's not as cheap and time saving as skin prick test. What is the evidence for this? It's D, policy level is option. The intervention says as a recommendation here that modified quantitative test can be used to determine a starting point of allergy in immunotherapy. So these were the medication list that I said I will mention. Remember to have a list for your patients, what they shouldn't take before allergy testing. I asked them to be 1 week without antihistamines. Anticyclic antidepressants is something you have to talk with their primary care or psychiatrist, whether that can be paused. And if not, you obviously do blood work. Omalizumab is the anti-IgE that if patient is on this, they have to be at least 3 months off it before you could do skin testing. Leukotriene receptor antagonist don't need to be stopped. Topical steroids might suppress a little bit. Systemic steroid don't really have much effect, as don't really do intranasal or inhaled steroid. So the topical steroids here is skin corticosteroids that can, especially if used on the large areas of the skin, may have some effect on the skin swell and flare. And what about the blood work then? I've already mentioned this. Total IgE is telling us that patient is atopic, but it's not specific. Immunoassays ELISAs measures the specific IgE. It's great on small children who don't want to get prick test or can't have it, when patients have demographism and single allergen IgE. Immunospot is something that's used for single allergens and mainly for research purposes. Total IgE is frequently increased in allergic rhinitis, but it has modest clinical utility. I use it mainly if I think about patients having high IgE, very high levels of either reaction on the skin test or in their allergy blood work, and I want to think about maybe they could be a candidate for anti-IgE, and then I want to see what their total level is. I aggregate evidence C of using this for diagnosis, policy level is an option, and it can assess the atopic status in the patients. Serum-specific IG, on the other hand, introduced 1967, first as a RAS test and now mainly performed by ELISA. It's very good test, safe, and there's no limitations whether the patient is on medication or have any skin conditions. Well, what about when you compare skin test and the blood work? Both can be used, and even the skin test allows immediate feedback and visible results, which help patients to see the reaction immediately. Blood work also gives you the results. However, neither skin nor IgE specific testing can definitely predict the severity or sensitivity. There are cross reactions for both, and specific IgE use more extensively quality controlled allergens and defined human serum controls. But nowadays we have a good controlled skin test allergen products available as well. Specific IgE can be used for multi-allergen screening. The levels of IgE correlates to the severity of allergic symptoms and may help you to select what immunotherapy, what antigens you choose for immunotherapy depending on their levels. The same thing you can do for skin test, looking for the size of the veal. Sensitivity 67 to 96%, specificity 80 to 100%. If this is compared to skin prick test or nasal provocation test, it's similar for the efficacy or sensitivity and specificity for allergic rhinitis diagnosis. Many ways equivalent to skin prick test, acceptable alternative to skin test. And like I said, it's safe. Grade of evidence is B, and this is the second testing that's recommended based on the evidence that we had for the ICAR document. And intervention, serum-specific IgE may be used in the evaluation of allergic rhinitis, and it's important that it's a reliable laboratory. Correlation. Studies suggest that skin prick test is up to 25% more sensitive than blood work, and skin prick test is about 50% cheaper. You get the reaction immediately, when often, at least for me, my patients have to wait 2 weeks for the blood work. Skin prick test is accurate and combined with detailed clinical history can confirm the diagnosis of allergic rhinitis. Sensitivity and specificity depends on allergens tested and the quality of the reagents, like for anything. So if you have a reliable laboratory, you have a good skin testing set. Both of these are very reliable and useful. Benefits are for the in vitro. The other one was about the skin testing benefits. Is like we talked about, you don't need to withdraw from any medication. Even if your skin is reactive and demographism, this works for you. And there is a cutoff for both sensitivity and specificity, and it's safe. They are not totally fully interchangeable to skin test and blood work. As we said, the skin prick test a little bit more sensitive. Skin prick test and intradermal test measure the end organ pathological mechanism associated with a specific IG bound to the surface of the mast cells. Skin prick test is often chosen as a first-line diagnostic instrument based on accuracy, convenience, cost, and promptness of results. That's how I do it. main go-to is skin prick test, but obviously patient selection and patient preference then also could make me to have them go and get the blood work done, whether it's a medication, they don't have time to stay for testing, and so on. Intradermal test is a second-line test, which we only use for doing our safety vial when we do immunotherapy. Other methods. You can use nasal-specific IgE. It has been used in the past, but now there's been also studies looking a local allergic rhinitis phenomenon where they said to have local IgE, specific IgE nasal mucosa. This is still research studies. Based on research studies, we don't have any clinical or products that would be able in the everyday clinic to measure the specific nasal IgE. At least we don't have it available, but it's potentially something for the future for those patients that looks like they have negative allergy testing, but still have reaction to certain allergens, especially in their nose. One of the ways to test this is to use steroid and nasal steroid and see if that helps. There is some studies suggesting that up to 45% of negative skin prick test or blood work patients that have still symptoms have local allergic rhinitis. I also suggested that up to 25% of patients referred to allergy clinics may have local allergic rhinitis. It can be seasonal or perennial. Low rate of conversion of local allergic to allergic rhinitis. An elderly patient, this could be up to 21%. Other way of doing this is not to take actually the sample from the mucus from the nose, but to use the nasal provocation test that I will show you. And this is also used for occupational allergic or occupational rhinitis diagnosis. Aggregation rate of evidence is B. Basophil activation test, mainly used for monitoring allergen immunotherapy. It's not available. It is still research test, but it's good to know that it's possible, and maybe in some of the studies you can use it. There are small-scale trials performed evaluating utility and reliability of basophil activation test for allergic rhinitis and monitoring therapy. Aggregated evidence is B, and it's rarely required. Component result diagnosis utilizes purified native or recombinant allergens. These specific allergens, like we know, a lot of the allergen mixtures that we use for testing has several allergens in them. For a lot of the allergens, let's say cat or dog or some of the weeds also can have several allergens that is most potent in different patients. So dividing them to the components of these different forms of these allergens, the epitopes, and looking into those might help in the future us to be more targeted immunotherapy. Right now, this is still quite rarely used, relatively expensive, and we don't have immunotherapy products that we could then use the results from this. But I think this is a future and very exciting way where the allergy testing is developing into. It uses ELISA, as does your specific IgE. Multiplex platform with 112 allergens are now available. It can better define the sensitization to inhalant allergens in patients who are polysensitized, unclear symptoms or sensitization patterns, not responding to treatment, but remains as a third-level approach, not a screening method. Evidence of grading is not available. This is so new that it hasn't really been used enough in a clinical setting to give a recommendation level yet. Sensitization versus clinical allergy. Like I said, you can have a positive test. That means that you have a risk for allergic rhinitis, but you don't always develop the disease. You can have absence of symptoms, even test is positive. Clear distinction has to be made between sensitization and clinical allergic disease. The quantification of blood or skin test using specific IgG titer and SBT wheel size increase the specificity of allergy testing in regards to the presence and severity of allergic rhinitis. So what it means the higher the level of the specific IgG in the blood, or the bigger the skin reaction, more likely patient have clinical disease as well. So what about the whole allergen extract, as we use mainly our individual allergenic molecules? The positive test on the whole allergen extract may reflect sensitization to cross-reactive components. Measuring sensitization to individual allergen molecules may be more informative than standard testing using whole extract. I already explained this in the pattern of if you have this available, the problem is that we still don't have immunotherapy. So age of onset of sensitization is crucially important, because then patient, more they get a sensitization, more often they start developing allergic march and other diseases as well. That's why we have to address the allergies early on. Atopic sensitization, more of an umbrella term for several different atopic vulnerabilities, which with the association with rhinitis, allergic rhinitis and asthma. Beyond IgE, decreased ratio of specific IgG-IgE is associated with increasing risk of symptomatic seasonal allergic rhinitis. And we are in immunotherapy making patients to form specific IgG4 blocking antigens, which then helps patients to not to get reaction and has less need for both medication and also less symptoms. Measuring allergy-specific IgC cannot be not recommended at this point. Chamber challenges are environmental exposure chambers, where they've been used for, especially for the occupational diseases. It can be used for diagnosis of asthma and allergic rhinitis. Nasal provocation test, that means that the allergen actually is put into the nasal cavity, when with the allergen challenge chamber, you inhale it in the chamber where this, let's say, pollen, or let's say it's occupational exposure for wheat. You are a baker and you get allergy reaction from that. For the eyes, you can use the similar products as you use for nasal challenge to see if your eyes are reactive. Nasal challenge is done directly into the nose, looking for bilaterally nasal secretion, nasal swelling, rhinometry, and acoustic rhinomanometry. Peak nasal inspiratory flow has not been well standardized, as is optical rhinometry, which was used at some point but not really shown. You could look for inflammatory markers, but this is for more the study purposes, and nasal nitric oxide has been also used. But again, most reliable and best published is the patient secretion and nasal obstruction, which is studied with rhinomanometry and acoustic rhinometry. Contraindication for nasal provocation test is infection, exacerbation of allergic rhinitis, history of anaphylaxis, severe general disease, and pregnancy. So what does ICAR say about nasal challenge test? These are gold standards. The chamber challenge is the most used for airway and mainly for asthma diagnosis, when nasal challenge obviously for allergic rhinitis. And it showed 4 studies that are level 2B. And it is, like I said, pivotal in the diagnosis of occupational rhinitis and also in studies of local allergic rhinitis. European Academy of Allergy, Asthma, Clinical Immunology position paper said that occupational rhinitis can only be established by objective demonstration of the causal relationship between rhinitis and work environment through nasal provocation test with the suspected agents in the laboratory. It's a gold standard. Aggregated level for this is C, and there are level 2B 4 studies. Chamber, I already mentioned that it's been used for lower airways and can be same time challenge both nose and the lungs. This is the runny nose on the right side in a picture, how you actually technically perform this. You put in the allergen into the nose and you follow patient at the 15 minutes and 30 minutes after the challenge. You measure how much mucus you can secrete it and weight it, and then you measure the rhinomanometry and acoustic manometry on those. And that's where you get the diagnosis. Local allergen challenge test for eyes has been also used. Aggregate level for this is C. It would be diagnosed for the especially the rhinoconjunctivitis, allergic conjunctivitis. Nasal cytology and histology. Nasal cytology in polyallergen patients shows more intensive inflammatory response than in monoallergic patients. Nasal cytology is a method of diagnosing nasal non-allergic rhinitis also, and has been used to differentiate between allergic and non-allergic. It's looking for mainly eosinophilics, and if those are not found, this was used to say that patient has non-allergic rhinitis. Aggregate evidence is for nasal cytology C and for nasal histology B. Nasal histology is done by biopsies, obviously, and the cytology, you just take the smear of the mucus. So I just kind of touched base. There are a lot of text on my slides, and I thought that you can go back and check that. I wanted to get you all the information from the ICAR and the recent evidence on these different testing methods. But just to conclude, skin prick testing in vitro and skin prick testing and in vitro ELISA testing are well-established allergy testing methods and recommended based on the level of evidence. Skin prick test is more sensitive than specific IgE. Intradermal testing is option, as is blended skin testing. Total IgE as well is a recommendation level of option. Local allergen challenge test, whether it's intranasal or chamber challenge, are gold standard for occupational airway allergy diagnosis. So if that's what you want to do, that's something that you should learn to do. Suggested reading is the ICAR document in the International Forum of Allergy and Rhinology 2018, and I already have a link there for the free copy of it for you. And then allergic rhinitis and its impact on asthma, that's the other one. Thank you for your attention for this chapter.